is new in the management of papillary thyroid carcinoma. So if you ask that question appears quite mundane if you take it on face value, because everybody would ask what is new. The papillary carcinoma has been there for long time. It's same old disease with very low mortality and very high recurrence rate. But what happens that over the time for any subject, new findings emerge and our understanding regarding that disease changes. So as I said, that papillary carcinoma of thyroid remains the same, but due to new emergent finding, our this thing understanding in how to manage these patients have evolved over the times. So what has changed? If you this thing look at the world data, so in many continents, particularly in America, Australia, and Korea, the incidence of thyroid cancer has increased by 3 to 5 folds. And what is the reason? So there could be many reasons. Many people ascribe it to the longevity of the population, dietary changes, environmental radiation, but all agree that majority of these patients, this increase rise in incidence has been contributed by our increasingly uh, becoming sophisticated investigation tool, and that is mainly high frequency ultrasonography. So majority, what happens that when we start applying high frequency ultrasonography for any neck diseases, we come across many papillary microcarcinoma, which would have otherwise been remain occult during our lifetime. So majority of this high incidence is contributed by these papillary microcarcinoma. But if we leave aside this thing, there have been so many new clinical findings and molecular findings which we have noticed uh, in past 2 decades, and that has led to our modified histology classification, new staging system. We have now some not very robust but better predictive and prognostic tools, and all these things in combination have led to new approach to the management of these patients. And there are some this thing new evolving concept in adjuvant therapy, and protocol has also evolved with this. So now coming to, I'll start with basics. So if you are this thing coming across any thyroid nodule, and so far as thyroid nodule is concerned, the basic tenets of diagnostic workup have not changed. Any thyroid nodule would be subjected to TSH estimation, FNAC, and ultrasonography. And here today we are concerned about papillary thyroid carcinoma. So majority of the papillary thyroid carcinoma would be easily diagnosed on FNAC, and that would be labeled as Bethesda category 7th on cytology. Sorry, Bethesda category 6. But there could be some small proportion of cases which would be either categorized as indeterminate and could fall in Bethesda category 3, 4, or 5, that is flush, follicular neoplasm, or suspicious of malignancy, and some cases could still be inadequate. So roughly between 2 to 5% of PTC would fall in those category. And what do you do about these patients? So people must have heard so much about pharma and multi-gene mutation panels, that is thyrosequence, and there are some others also commercially not available in India, but in US and abroad. And those are basically categorized into rule in or rule out tests. We need to remember that even in category 3, 4, and 5, the majority of the cases who turn out to be malignant would still be papillary carcinoma thyroid and not follicular carcinoma as we thought initially. So it could be follicular variant of papillary carcinoma, but those majority are papillary carcinoma. So here for this thing, understanding of our own postgraduate, we may not need those panels for our own cases. Even if you have access to RET PTC gene or BREF, immunohistochemistry, and if any of these category of aspirate test positive for PTC, RET PTC, or BREF, you are almost sure that these you are dealing with papillary thyroid carcinoma. So that is one of the practical application of our molecular understanding of these cases. And for inadequate, we jolly well know that we can repeat the aspirate after 6 weeks to 3 months. And in majority of cases, in 80% of cases, we would be able to make up the diagnosis. But remember that in inadequate category, the incidence of malignancies is higher than what we find in Bethesda category 2. Now, is there anything new about imaging? I would say no. This thing and the concept of and recommendation for imaging would be as it used to be previously. We need extensive imaging only in cases of retrosternal extension, when patients have bulky lymph nodes, or we are dealing with reoperative setting. Now, this is a I would not say new, but relatively tool, FDG PET. And while you are sitting in clinic, every second patient would be, if you tell that patient that your diagnosis is malignancy or cancer, so that patient would be asking whether they would be needing this imaging or not. So answer in majority of cases should emphatically be no. But we generally recommend this imaging in follow-up situation, and that too of tennis, when this thing thyroglobulin level is rising, but patient's tumor has lost radioiodine avidity. However, if you look at recent ATA guidelines, they say that if you are dealing with a metastatic disease, you could use this modality, and probably this thing uptake of FDG PET by tumor in this situation help you identify the patients who are high risk for rapid disease progression and disease specific mortality. So this could maybe use as a prognostic tool in that situation. So, and this thing but otherwise in pre-op situation you don't need this modality. So before going to your newer insight into histology classification, we all need to remember this diagram. So this diagram, I think all of you could recognize it. This is dealing with MAP kinase pathway. So mitogen activated pathway, and that is the major pathway responsible for thyroid cancer oncogenesis. And here, if we look at this pathway, the receptor at the main receptors are tyrosine kinase receptors, and one of the oncogenes are RET PTC. And subsequently, once this pathway is activated, they lead to activation of RAS, BRAF, MAC, PRK, at a cytoplasmic level. Thereafter, these are translocated to intranuclear location, and in turn, this lead to cell differentiation, proliferation, and increase and enables cell survival, and that in nutshell results in malignant thyroid disease. So here we need to remember, so what is this thing, main purpose of showing this diagram is that we need to remember that these are main constituent of this pathway, and all these oncogenes could be exploited for diagnostic, therapeutic, and classification of thyroid cancers. So many of our targeted therapies target these very oncogenes, and many of this thing our histological classification has looked into the presence or absence of these genes, and presence or absence of combination or different combination of these genes have resulted in different morphological expression of papillary thyroid cancer. So I think all of you are familiar with this panel, and all the students who have role in endocrine surgery course or endocrinology can recognize these slides from a yard of distance. Needless to say, this is a beautiful slide showing papillae with fibrovascular core, and that is a classic presentation of classic PTC. If you look here, papillae are absent, but you could still see very characteristic nuclear features of papillary thyroid carcinoma in form of nuclear curing and intranuclear inclusion. Now coming to third, the same features are there, cells are also same, but if we look carefully, you can see that the height of cell is more than 2 times than the width. So if you if I can summarize, I think all of you by now can make out the diagnosis. This is classic PTC, this is follicular variant of PTC, and this is tall cell. So our recent classification, which has been provided by WHO, was published in 2017, and that is fourth edition of histologic classification of endocrine tumors. So what is new in that? So this commentary I have taken from a beautiful article which was published in Pathology International. So what they have done is, actually they have done away with the concept of benign and malignant tumor. So now this thing, our understanding says that there is no watershed line between benign tumors and malignant tumors. And essentially there is a continuum between benign, undeterminate malignant potential, NIFTP, and malignant tumors. So, and there are new terms introduced. NIFTP, now it is well established and most of you know about this NIFTP, and they have done away with presence of papillae. Initially, they said that if papillae are less than in 1% of tumor, then it still qualifies as NIFTP, but no longer. And then they have dissected more about hyalinizing trabecle tumor. We have been knowing about this tumor for long, but now we know there could be a certain malignant potential associated with this tumor. Then histological variant of papillary carcinomas. There are currently 15 variant if you include classic in the list. So we know how to classify them as aggressive, and certain of these variables are associated with hereditary tumor syndrome. So that it's a non-medullary hereditary thyroid tumors. Though these are incidence is less than 5%, but still we need to know about these tumors. Follicular carcinomas, initially we were dividing into only two categories, minimally and widely and invasive category. Now we have three, and in between is a minimal invasive uh, uh, or angio-invasive category. So one is minimal invasive where only capsular invasion is present, then angio-invasive where less than four foci of vascular invasion is present, and of course there is widely invasive. So angio-invasive is in between minimal invasive capsular and widely invasive behavior wise. So I will not cover poorly differentiated thyroid carcinoma, which is not the part of today's topic, but this thing, we need to remember that value of many genetic markers like BRAF V600E and TUT mutation in thyroid carcinoma. So presence of both of these mutation is considered to uh, considered to uh, considered to provide aggressive behavior to a particular PTC. And in current classification, it is emphasized that not only thyroid tumor per se, but surrounding environment should also be examined very thoroughly. I'll come later in my presentation why that is so. So as I said, there are 15 variant if you include classic variant also. And if you go one by one, there are the excellent variant, prognostic variants are papillary microcarcinoma, encapsulated, and follicular. Papillary microcarcinoma, the genetic alteration commonest present is BRAF, and in follicular variant is RAS. So it is, but it is very important to remember one thing, that BRAF mutation, whether it really imparts an aggressive connotation to a particular tumor or not is not a very settled debate, because BRAF mutation is the commonest occurring mutation in PTC. And as a student of endocrine tumor, we know that while BRAF may be a very common mutation, but most of the thyroid tumor are very indolent, and only 10 to 15% are aggressive. So there is a big gap in our understanding, which explains what provides a aggressive behavior to thyroid cancer in presence of BRAF mutation. Then there are other this thing less favorable type and high risk are diffuse sclerosing, tall cell, columnar, Hobnail variant and solid trabecle variant. Solid trabecle variant is particularly important, and this we should remember that this is mostly seen in children, and this is one of the commonest mutation associated with it. It is RET-PTC3, and these tumors are mostly seen in post radiation situations. So post Chernobyl and post Marshall Island explosion, this was the tumor and this was the mutation which was mainly present and which has been extensively studied by an now American pathologist, Nikiforov. And then this histologic classification also have provided us a cutoff for designating a tumor into particular tumor subtype. NIFTP I have already covered. For follicular variant, almost 100% tumor should be harboring this kind of uh, morphologic uh, presentation. And same is true for solid and trabecular variant PTC. For tall cell and hobnail, more than 30% area should be harboring this kind of pathology. Spindle cell, we are not very much clear about this entity as of now, but it is important to remember that spindle cells are also present in anaplastic carcinoma, and whenever diagnosis of this tumor is being made, we need to exclude that with certainty. And as I said, I would not be dealing with poorly differentiated carcinoma, but it is important to remember that poorly differentiated areas may be present in otherwise indolent kind of tumor. So any classic PTC may harbor poorly differentiated area. What is the prognostic implication of this thing? That understanding is still evolving, and we have not reached that final conclusion in this regard as of now. So as I said in the beginning, the major difference between third and fourth WHO classification is that this watershed distinction has been done away, and now we could consider thyroid tumors or neoplasm as a kind of continuum. So that starts from hyperplastic nodule, benign tumor, borderline tumor, low risk cancer, moderate risk, and high risk cancer. So the main point for us clinician is that we should not dismiss any histology as of no consequences so far as recurrence or distant metastasis is concerned. So even if this thing like NIFTP has been classified as kind of non-cancerous tumor, but we need to keep these patients on close follow-up. Now coming to our TNM staging, or American Joint Committee on Cancer, or UICC staging as we call it. And the recent edition which we are having in practice is 8th edition. So what is the difference between this edition and 7th edition? So as I said in beginning, that papillary carcinoma are usually of a very indolent nature, and chances of overall mortality in fact associated with these tumors is 10 to 15%. And we know that low risk tumors have very less mortality. So what was the problem with initial classification is that there was based on this staging, we could not predict uh, mortality with great accuracy on staging system. So there was not much of a difference of mortality in stage 2 and 3, and same between stage 1 and 2 so far as classification for adults are concerned. So now what has been done, that they have taken into account so many randomized control, not randomized, so many this thing studies and observations, and based on that they have raised age cutoff from 45 to 55. So initially if this thing, like we say that old is a uh, bad prognostic factor or adverse prognostic factor for PTC. So, but that cutoff now would be 55 and no longer 45. Minimal extrathyroid extension to strap muscle is of no consequence so far as uh, imparting aggressiveness to a tumor. However, if there is a macroscopic invasion, that still remains a adverse prognostic factor. So if we this thing apply this classification to our patients, and if we compare it with previous staging system, then we can see that there are so many studies have been published that approximately 30 to 40% of the patients would be down stage, and at the end of the day, we would be left only with 5 to 10% of tumors, which are basically classified as stage 3 or 4 on basis of presence of T4B tumor resistant metastasis, which are really aggressive and which have 5-year mortality of 50%, 40% or more. Otherwise, for low risk patient, we know 20-year mortality is approximately 2%. So if we just compare these two classification, so as I said, the major difference so far as diameter is concerned, that has not changed in this thing, categorization of these tumors. The main difference is like previously, um, if a tumor was invading sternothyroid, it was classified into T3A, but no longer for now this thing, any for to be classified into T3 category, the tumor should be invading not only sternothyroid, it should be invading outer stap muscles as well. The second major change is that for N0, they have categorized in two category. So usually what happened, we ascribe a patient as N0 status based on clinical radiological finding, no palpable node, not visible on ultrasound. However, if we have biopsies these nodes, at least one or node, and if that turns out to be negative, then we would label it N0A. And if we are still labeling it N0 based on our clinical and radiological finding, it would be N0B. So far as N1A is concerned, upper mediastinal nodes are also now clubbed as N1A. Previously, those were clubbed as N1B. So these are 1, 2, 3 major changes so far as TNM categorization is concerned. And the grouping, how it is different as compared to previous system was that previously T3 was tumors were grouped as stage 3, but no longer. Now, if the patient is having T1 and T2 tumor with lymph nodes involvement, these are still classified at stage 1 and 2. Previously, T3 and presence of lymph nodes would upgrade that patient into stage 3, but no longer. So that is one of the major change. Now coming to management. So one by one, as we know, the three major armamentarium available to us is surgery, radioiodine therapy, and TSS suppression. And for advanced patients, some patient would be needing TKI. I would not touch upon EBRT at all. And there would be some other emerging modalities. So I'll deal one by one what has changed so far as our three main constituents of management are concerned. So now coming to surgery. And as I said initially, that majority of the increased incidence has been contributed by presence of papillary microcarcinoma or carcinoma which are less than 1 centimeter trial. So what should we do about it? So if you look at the current guidelines, majority of those are increasingly advocating surveillance for these tumors. But where did it come from? So we should always remember Ito and Dr. Miyauchi from Kuma Hospital, Japan, who initiated this project. And their first report came in 2003, and subsequently they published 4 or 5 papers on this aspect. So the current one, which this thing, not recent one, but this was present in 2010, and this was a kind of quite robust data where they had followed more than 1,000 patients for 10 years. And what they have observed is that growth, which they have labeled as more than 3 millimeter, was seen only in 8% of patients, and lymph node involvement in half of those. Like 4% patient had lymph node involvement, 8% have tumor enlargement. And by this thing, their analysis, they found that young age, that in their analysis was less than 40 years, was an independent prognostic factor for tumor growth and lymph node involvement. And one of the important finding was if these events occur and the patients are then subject to rescue surgery, none of those patients died after rescue surgery. So in nutshell, it doesn't matter whether I operate that patient today or after 5 years or so. On similar line, this thing, Michael Tuttle also conducted, and their group also conducted a trial in America. However, this thing, tumor size included in their trial was uh, 1.5 centimeter or less, and they followed these patients up to 2 years. And similar to that finding, the growth was 2.5% at 2 and 12% at 5 years. And similarly, they also found that young age was a predictor for growth. So actually this is, if you think, this is slightly paradoxical from our own understanding. Our own this thing, the classic and conventional understanding is that older patients have bad disease. But so far as tumor growth and lymph node involvement is concerned, in all these trials, it was found that it was higher in younger patients. So based on these two major trials, and there are currently some trials which are undergoing in Korea and Israel. Probably we have some more clarification in the areas where this thing understanding is just not very clear. But it could be said that majority of these patients could be observed, except where you think that observation would be inappropriate. And what could be those factors? Those factors could be either tumor related, when tumor is just in subcapsular location where it is likely to invade surrounding organs, or recurrent laryngeal nerves, or FNA findings suggest aggressive cytology, and a patient already is having metastatic disease. Not only tumor size, but distinct presence of lymph node and metastasis should also be taken into consideration. So if the metastasis disease and lymph nodes are present, you are not going to put that patient on surveillance. And young patients, and obviously those who refuse to be under surveillance, and if the physicians are not competent enough to provide proper advice and guidance, and there are not good ultrasonologists available, then in those cases it is better that you advise for surgery. So otherwise, if you look at 2015 ATA guidelines, active surveillance is the main option of treatment for papillary microcarcinoma, except the points which just I elaborated just now. And if a patient is already under observation, if you note tumor progression of more than 3 millimeter after 6 months, then you have to subject that patient to surgery. So in that case, we could say that majority of these patients might not require any active therapy. Now coming to lobectomy. So this debate of lobectomy versus total thyroidectomy, or hemithyroidectomy versus total thyroidectomy, is one of the oldest in, I would say, medical history. But this has again come into forefront. So what has this thing led to? Our conservative approach is that now we have quite long-term data, and those are very objectively maintained databases. So based on that finding, as such, we always knew that mortality is virtually unheard of in low risk thyroid cancer, whether you, it hardly matters whether you perform total thyroidectomy or lobectomy. And but main concern has been recurrences. And initially it was thought that recurrences is probably in two figures, it could range between 14 to 18%. But recently, majority of the studies would say that recurrence is less than 10% in hemithyroidectomy uh, versus approximately 5 to 7% in total thyroidectomy. But only one study which emerges from SEER database that say that there could be difference in mortality. But and that mortality, since the number of patient included was quite huge, more than 50,000, so they found a significant difference in mortality. But however, if you look at the number, 2.9% versus 1.6%, so absolute number is not much different. So what I mean to say is ki though there this thing it could be statistically significant, we whether it is really clinically significant or not is a matter of debate. And apart from this study, all the studies says the mortality is uh, not much different in total versus lobectomy. And what are the advantage? So obvious advantage is that you virtually obviate the need, obviate the risk of permanent hypothyroidism and bilateral recurrent laryngeal palsy, and you are definitely going to half the rate of unilateral recurrent palsy, and majority of the patient would be spared of thyroxine supplement. Though it is not 100%, and in various series the hypothyroidism rate could vary from uh, 25 to 40%, but it is definitely significantly less than total thyroidectomy where hypothyroidism is a certainty. Now coming to second part, and that is, so far as lateral neck dissection is concerned, there is not much debate in papillary thyroid carcinoma. And whenever you find that clinically or radiologically or cytologically proven lymph nodes are present, you have to address those by therapeutic dissection, and there is no role of prophylactic lateral neck dissection in PTC as opposed to MTC where it could be applied. But the main debate in here is prophylactic central compartment lymph node dissection. We know that the chances of recurrent lung palsy and permanent hypoparathyroidism is significantly high in prophylactic central compartment lymph dissection cases as opposed to only total thyroidectomy cases. Even in this thing experienced hand, the risk would be at least 1 to 2% high. And if you look at these cases, if that uh, difference in mortality is not more than 2%, why would you subject these patients to unnecessary morbidity? And we know that even if microscopic lymph nodes are present, like if we don't dissect a particular, if we dissect a patient where there is no clinically apparent lymph node, you could find microscopic lymph node, this thing ranging from 10 to 60-70% patients. But if you don't this thing do anything and just follow up these patients, these are not going to become clinically significant in coming 10 years. So that's how this thing current concept is for low risk tumors, that is T1 and T2, prophylactic central compartment lymph node dissection is no longer recommended. However, if you find significant clinically or cytologically proven significant nodes, those would require therapeutic dissection. Now, Dr. Gyan has very beautifully shown how you could perform minimal invasive or remote access surgery in thyroid. So that would be a different kind of debate whether those have become a standard of care so far as low risk thyroid cancer is concerned or not. But definitely for high risk invasive cancer, you are not going to attempt these surgery. However, whatever surgery, even if you do open surgery, we have certain adjunct which either facilitate our surgery in form of energy devices or help in prevention of morbidity. So the main two morbidities are recurrent palsy, and we have now neuro monitoring available with us. Though most of the meta-analysis and systemic review have failed to show any benefit of or reduction in morbidity with the application of these instruments. However, all agreed that these should be used in certain cases like reoperative setting and difficult and in cases where patient is already having one side retinal palsy and you are going to operate on second side, then you need to have to access to this monitoring. So, and if you use in only one of case, you won't be gaining experience. So maybe for learning purposes, we should know how to perform neuromonitoring in case while you are doing thyroidectomy or parathyroidectomy. Now the second component or of morbidity is hypoparathyroidism, and we have many newer adjuncts which help in identification of uh, parathyroid, including isocyanine green, autofluorescence, and carbon nanoparticle. Now coming to the second most important part of PTC management and the most important adjuvant therapy, and in fact all of us know this is one of the oldest target therapy because radioiodine specifically go to the thyroid cancer only and not other surrounding structure to the most of the extent. So what has changed? So like you must have gathered from the talk until now, mostly where we are doing less. So less is more in low risk cases. So low risk cases, whether this thing we can avoid radioiodine therapy or not. So if you look at this thing, this controversy is still far from settled, and only consensus have been reached till now is that radioiodine therapy could be avoided in intrathyroidal papillary microcarcinoma. And most of the authority would also agree that it should not be applied in low risk cases. As such, if you are performing total lobectomy in these cases would automatically become unfit for radioiodine therapy, though some nuclear medicine authority would claim that they can ablate uh, the intact thyroid lobe with radioiodine. But if it is this thing really required, why not to go ahead and perform total thyroidectomy? So this part is clear, but this selective use of this therapy in intermediate cases, there lot work has to be done in these cases because what you consider intermediate keeps on changing. Like some would say if tumor is more than 5 centimeter even without extrathyroidal invasion, some would say there are more than 4 microscopic lymph node that makes it intermediate. Some would say aggressive histology, but on the other side some other people would say if it is, even if it is aggressive histology, tall cell carcinoma, but the patient is 25 year and it was completely intrathyroidal without lymph node involvement, we may skip radioiodine therapy in that case, those cases. So this area is and debate is still continuing, and our understanding is evolving. But what is certain that if we are recommending radioiodine therapy in these cases, we may do it under recommend recombinant human TSH injection. Patient need not to have endogenous TSH stimulation. Currently, there are 2 RCTs. This thing they are enrolling low risk patient in France and UK, and the primary outcome of these 2 studies are disease-free survival rate at 3 and 5 years. As such thing, I said there is the risk of mortality is very low. Therefore, the primary outcome has to be disease-free survival. So let's see. Wait for results of these 2 trials. One is being conducted in France and other in UK. Now, third most important aspect of therapy is TSS suppression. We know that levothyroxine therapy significantly reduces DTC recurrences and cancer-related mortality. But what should be the TSH level which is optimal to achieve this objective is not very clear. And TSH suppression uh, leads to increased risk of atrial fibrillation and osteoporosis in older patients. And as we know that our society is aging, and most of these tumors, papillary thyroid carcinoma, are being diagnosed in older people. So we need to be very conscious about prescribing radio TSS suppression in older patients, particularly those who have this thing low risk. So by virtue of age only, you should not be prescribing TSS suppression. So we have to this thing balance likelihood of complication and risk of recurrence. And so far as low and intermediate risk patients are concerned, so there is no evidence that suppression would lead to better outcome. And the goal of supplementing thyroxine in these cases should be that we should maintain TSH within normal range. Now, this was all about primary PTC. But is there any other new insight into management of recurrent disease and distant metastasis? So I would say yes. When we used to be a student, that time it was a dictum that if patient is having multiple metastasis, radioiodine or systemic therapy is the treatment of choice. But if you look at this in Bruno Niederle paper from Vienna and other paper from America, they say that even this thing in presence of multiple skeletal metastasis, and Bruno Niederle group have excised up to more skeletal metastasis. What they have this thing observed is that resection of these metastasis not only uh, uh, leads to improved quality of life, but survival benefit also. So if we look this thing, our reference point is ki what is the survival rate in stage 4. So it used to be like 4-year, 5-year survival rate used to be between 40 to 60%. But when they applied a metastatic to these patients, that survival rose to 60 to 80%. So resecting or debulking, I would say, does help. It has been proved. There are not this thing many studies, but some studies which are there in literature um, points towards that. And in fact, in our own experience, we published that in World Journal of Surgery in 2016, though our was not curative intent, but wherever we resected, we found out that our 5-year survival rate was 60%, and our this previous benchmark was 20 to 30% in metastatic disease. So resection does help. So wherever this thing, if there is accessible metastasis which could be resected without significant morbidity, we should go in and try to resect that. Because as such, we know that thyroid cancers are very slow growing cancer. So it does help the patient. And for aerodigestion invasion also, if there is luminal invasion, resection with R0 margin results in survival benefit and definitely improve quality of life. Patient would be relief of hematemesis, compression, dysphagia, dyspnea, and so on and so forth. Then coming to recurrent lymph node. So classically we were taught that for lymph node, the best modality is surgery. In fact, these are resistant to radioiodine therapy. But as we know that recurrence are quite frequent in necks, and a patient who initially presented with multiple lymph nodes is one who is likely to come back again and again with lymph node recurrence. So in these situations, we have many new modalities which if that node is not situated in the vital portion over the carotid artery or the laryngeal nerve, we could ablate those. And there are many modalities available for that. It could be done with radiofrequency ablation or ethanol injection as well. Now coming to targeted therapy. So there would be a case when this thing metastatic disease becomes radioiodine refractory and disease is progressing. Then many of these patients or some of these would require targeted therapies or systemic therapies, and mainly this thing we give them in form of tyrosine kinase inhibitor. And we know that these have shown to prolong progression-free survival, though overall survival is not prolonged in these patients, but progression-free survival definitely gets prolonged. And two main therapies which are available to us is sorafenib and lenvatinib, and we know that decision trial and select trials uh, led to our understanding that there could be some objective response to the tune of 12 to 65% respectively with use of these therapy. So, but it is very important to note that if the patient is asymptomatic, there is no significant progression of disease, you should hold back this therapy, because these therapy come with their own side effects. So we have to balance patient's quality of life with this tumor progress. And uh, obviously in our country now many generics are available, but previously finances used to be a major limiting factor. Then there are some therapies which are being tried and to restore radioactive iodine uptake, because as I said, radioactive iodine has been the most important target therapy so far as thyroid cancers are concerned. So people have tried using selumetinib, which is MEK inhibitor, and darafinib, a selective BRAF inhibitor. I'm sure you must be knowing that this is being used in ATC nowadays in combination with other drugs. Then there are other, like I said, key, not only thyroid cancer, but environment should also be looked into. So if there are TILs similar to breast cancer, so if there is tumor infiltrating lymphocytes, and if this thing tumor and or those cells, they exhibit PD1 or PDL1, uh, then these cancers would be amenable to anti-PD1 antibody, and some of them are already in market for commercial use. But for breast cancer, but for thyroid cancer, the trials are still going on, and we are getting newer and newer drugs which target BRAF V600E in particular, like Vemurafenib. So if we go back to our MAP kinase pathway, so remember all those oncogenes, and in future there are some trials are currently undergoing, and in future we are likely to have more molecules which could be used against uh, radioiodine refractory thyroid cancers. So now coming to follow-up. So is there anything new about follow-up? Not much, but we know that our current TG assays are much more sensitive, and they can detect very low level of concentration of TG as well. And that's why this thing, those could be employed in situation where patient continues to take thyroxine supplementation, though cutoff for low risk patient is not known, but those patients could be followed up with serial TG as well. Now there is, but so far as TG estimation is concerned, we know anti-TG, presence of anti-TG antibodies, a big hindrance in proper evaluation of these cases. So some work is being done on mass spectroscopy, which could measure TG in presence of TG antibody. And uh, just now we discussed, radioiodine scan is no longer recommended for follow-up low-risk patients. Neck ultrasound continues to be the modality of choice, and we are having some work on circulating microRNAs and other nucleic acid, which could be used as tumor marker in future. But as of now, they have not become standard of care, because these are not very specific kind of biomarkers. Now quickly coming to this assessment. So previously we used to have only one risk categorization. We would categorize patient to high risk or low risk, and that's it. But no longer that is so, and we know now this risk assessment has also become dynamic, and we assess the patient how this thing after therapy, and we look at how the patient has responded to therapy, and response is categorized as excellent, indeterminate, biochemically incomplete, or structurally incomplete. I know all of you know this thing. You can look at ATA guideline, what we all know about these categories, and this thing from excellent to structurally complete, the risk of mortality increases. And it's very important to remember whatever recurrences are there, more than 75% takes place in initial 5 years, but there is no period of time beyond which you could declare a patient completely cured. Therefore, lifelong surveillance is still recommended. But what happens with this application of dynamic risk assessment system is that even if a patient is initially designed as designated as high risk, but if that patient respond excellently to therapy, then that patient is likely to remain disease free for a long time, and we can have less intense follow-up of these patients than what we originally planned. So at the end of day, I would this thing conclude. This is one of my favorite slides. So whenever we look into management of thyroid cancer, there are guidelines, and these also keep on evolving. So what does it tells us? That nothing is constant, but change. So we keep on this thing as a student of endocrine surgery. We keep on this thing referring to literature and reading about basic pathology, physiology, and newer literature about thyroid cancer. And that changes our understanding and the way we manage our tumor. So I'll stop here. Thank you very much.